welcome to Rounds, Research Rounds, again, hybrid event. So if you would like to be see this in person and live with the illustrious Dr. Birnie, please do join us, but otherwise welcome online as well. For those in the room, any questions following the presentation, please use the stand-up microphone at the side. And for those joining virtually, submit your questions in the Q&A feature as per usual. And we'll also be accepting live questions if you just raise your hand. If there's any technical issues, use the chat features. So today we'll be hearing from our illustrious division head, Dr. Birnie, who's the varied chair in cardiology. And obviously we know he's a staff electrophysiologist and full professor of medicine at the University of Ottawa. David, as we know, trained in Glasgow and at Aberdeen University, and did a fellowship in Glasgow, followed by training here in Ottawa, and then eventually joined staff. It seems like yesterday, but it was 20 years ago in 2002, and he's been a nonstop ever since. He is a founding member and I believe current chair of the Heart Rhythm Society. He is a principal investigator for multiple grants through multiple organizations, peer-reviewed organizations, and he has over 500 peer-reviewed presentations and publications to his credit. And he has received many illustrious awards, including the Department of Medicine Mentorship Award, as well as the Global Achievement Award for the Institute. His focus obviously is EP and radiofrequency ablation, simple and complex arrhythmias, including atrial fibrillation, and also cardiac sarcoidosis, with major clinical interests in all of these areas. David has been an inspiration. He's been a leader, and also has been always able to keep things light with his great sense of humor as well. His title is to fake it until you make it, but he's never really had to fake it. So we do look forward to his presentation and to highlight some of the achievements of his recent research and where the future is going in the field. David.
Thank you, Dr. Beanlands. For those of you who are watching online, Dr. Beanlands is now actually leaving. So fake it until you make it. You know, I give credit to Andrew Pipe for the title. Andrew Pipe, I knew the phrase, but he provided the context. Many years ago, we used to have these wonderful research brainstorming meetings before the Great Plague hit us. We used to have these brainstorming meetings in Peterloo's house, and he'd provide lots of beer. And anyway, Andrew Pipe once told me the concept of fake it until you make it. So these are my disclosures. For years, I never had any disclosures for cardiac sarcoidosis research, but very interestingly, these are two small pharmaceutical companies who develop novel compounds for orphan diseases, who very recently have contacted me about two very interesting novel compounds that they're developing for treatment, for the treatment of sarcoidosis. So this is my outline of my talk. I'll start with case one in my career. I'll then talk a little bit about the background of the disease, the diagnosis of cardiac sarcoidosis, underdiagnosing cardiac sarcoidosis, and then the major section will be on ongoing research, and then we'll go back to our case towards the end. So this is case one in 2006. It wasn't Alicia, if you like, good wife, but it was a 57-year-old lawyer who came to me in 2006 with this ECG, which is 2-to-1 AV block. So at that time, the standard of care was to put a pacemaker in and discharge the patient home. And that's exactly what we did in 2006. But 2 years later, she represented with sudden onset of breathlessness, and she was thought to have had a pulmonary embolus. And she was in the emergency room, and they did a CT scan looking for a pulmonary embolus. And what they found was two things. They found that she had findings consistent with pulmonary sarcoidosis, and they also showed that she was in heart failure, and an echo showed an ejection fraction of 25%. So Alicia went on and had a $1 million workup. And this is our favorite scan in sarcoidosis. You'll see me show lots of these. This has been a wonderful collaboration with Dr. Beanlands, Dr. De Kemp, and all of the imaging colleagues who are a huge part of this success story. So anyway, the PET scan is an FDG PET scan. FDG is an isotope that's preferentially taken up by activated macrophages. More than that, if you have more questions than that, Dr. Beanlands has returned, so you can ask him at the end. But basically, this is highly abnormal uptake in the heart and highly abnormal uptake in the regional lymph nodes. A lot of this is normal secretion of isotope, but this is highly abnormal. So Alicia has lots of questions for me. So she asks me, why do I have this disease? How should we treat it? What's my prognosis? And most importantly, why did you miss it 2 years ago? So I went away in 2006 and I read everything I possibly could read about cardiac sarcoidosis in the literature. And I came back and I said to her, I have no idea why you've got this disease. I have no idea how to treat it. Your prognosis is really bad. And I'm really sorry I didn't diagnose it 2 years ago. And that's really the start of the research from that point onwards. So a little bit of background for folks who don't know much about sarcoidosis. The history is this, that it was diagnosed initially in the 19th century by two dermatologists. And initially it was thought to be purely a skin condition, and it gets its name because it was thought to be a relation of sarcoma of the skin, but to be completely benign, and that's where the name came from. But then later on it became clear that it was a systemic illness. And this is what we're taught. This is what I was taught in medical school 30 years ago, and it is probably still taught similarly today. And I actually would argue that it's not quite accurate, but more than 90% of cases of sarcoidosis have lung involvement. Skin is number 2. And then the cardiac involvement is often quoted as between 5 and 30%. The epidemiology of the disease is absolutely fascinating. It's very rare to have the disease below the age of 25, and it's very rare and it's unusual to have it over 45. That's sarcoidosis. We're seeing in the cardiac sarcoidosis population a slightly different epidemiology. We rarely see it below the age of 35, and we rarely see it above the age of 65. The incidence varies widely around the world, perhaps related to environmental exposures, perhaps related to surveillance methods, perhaps related to immune factors and other genetic factors. The highest prevalence is in Northern European countries, and that's why we're seeing so much of it in Canada amongst the immigrant population from Europe. And the long-term risk of sarcoidosis in North America is thought to be about 2.4% for African Americans and about 0.85% for white individuals. So not a rare disease. What about cardiac sarcoidosis? It's often said that 5% of patients have clinically manifest disease, but that 5% really is a number picked out of midair and really isn't epidemiologically soundly based. But these patients are at the severe end of the spectrum, like Alicia, who presents with heart block, develops heart failure, and many of them develop ventricular arrhythmias. There is also a subtype of disease that's the epidemiology is much better understood, and that's patients with clinically silent disease. For example, patients with pulmonary sarcoidosis, and you do an MRI and they have a small patch of disease, and we call them patients with clinically silent disease. The cardiac sarcoidosis. Generally, it's three features, or three elements rather. There has to be typical manifestations. We have to exclude other diseases that may present similarly. And number three, usually we have to get a biopsy showing typical non-caseating granulomas. These are the first international guidelines on the diagnosis of cardiac sarcoidosis. And as you can see, within 8 years of faking it, I had made it, and I got to be the chair of this guideline document, mostly by luck than anything else. The president of the Heart Rhythm Society, which is a almost 100% US organization, happened to be a Canadian that year. And so she spoke very highly of me and got me to be the chair. So that was very, very lucky. These are the diagnostic guidelines. And I have to say also, these are based on nothing more than a bunch of people just making stuff up in a room. There's very little science to support these guidelines. And we hope to iteratively improve them. They've never been validated, but they're about to be validated. They're about to be validated. I know this because we're just starting the first validation project of these CS diagnostic guidelines. And there's quite a science to validating diagnostic guidelines. I had to go away and read a fair bit of epidemiology and get George Wells. I even started to stretch George Wells's knowledge, which has never happened before in my experience, but we're starting this project to validate the CS diagnostic guidelines. And as part of, the purpose behind validating is also to see where they're lacking and iteratively improve them. So are we diagnosing cardiac sarcoidosis? I don't have time to show you all of this data. A lot of this data comes from our group, but also in others. We showed that in a population of patients presenting to our institution here in Ottawa, that roughly a third of patients aged less than 60 presenting with idiopathic heart block have actually got undiagnosed cardiac sarcoidosis. Similarly, patients presenting with truly idiopathic VT. I don't mean VT related to coronary disease or VT related to, RV outflow tract, but truly idiopathic VT. Perhaps about a quarter of them have cardiac sarcoidosis. A lot of ARVC is actually misdiagnosed and is actually cardiac sarcoidosis. And the last one is interesting. There's now been 4 papers showing that a lot of cardiac sarcoidosis is actually missed. And when you look at the explanted heart at the time of transplantation, somewhere between 3 and 5% of these patients actually have cardiac sarcoidosis. So rare, but not that rare, perhaps. So now on to some of our ongoing research. The first project I want to tell you about is work that really Daryl Davis is doing. I'm very peripherally involved, apart from sending him some money from time to time and also some intellectual input from time to time. Sophie van Romertel is the master's student that's doing most of the work in Daryl's lab, but Daryl is trying to develop the world's first animal model of cardiac sarcoidosis. So I think he's quite enjoying it, and we're making considerable progress. So he started off by injecting carbon nanotubules into the septum of these mice. Now, the thinking behind this was carbon nanotubules have been used in a pulmonary sarcoidosis model pulmonary sarcoidosis animal model. So we thought we would try the same. So this is Daryl or maybe Sophie injecting into the septum here. And when you actually look at the histology of it, they actually were able to find quite typical granulomas. But after the first series of experiments, they found that they weren't getting any fibrosis in this animal model, all they were getting was inflammatory lesions and no fibrosis. So Darrell then went on to modify the animal model by doing a thing called transverse aortic constriction, which has been used in animal models for left ventricular hypertrophy. And it seemed to be the combination of the nanotubules and the transverse aortic constriction seems to be working. And these are some of the data that Darrell's producing. If you look over here, this is the Qrs duration on ECG 60 days after these injections. And the Qrs in the sham mice goes from 20 to 20 milliseconds, but in the experimental mice, they go up to 36 milliseconds. And they also showed that the ejection fraction falls as well. The next step in the project is twofold. We're hoping to make use of the small animal PET scanner to see whether there's inflammation in the regional lymph nodes as well, which would really clinch this as an animal model. And the second thing is we're planning an RCT in the mice, randomizing patients to prednisone against placebo, again to validate the model. Next, I'll show you some of the data that we're doing, some of the research we're doing into investigating the etiology of sarcoidosis. So what is the etiology of sarcoidosis? And the answer is it's not known. The current hypothesis is that somehow genetically susceptible patients are in the wrong place at the wrong time and come across something in the environment or some infectious agents, or perhaps a combination of environment and infectious agents, and then there's an auto-inflammatory response to these triggers, and the disease develops. So this is the best study looking at epidemiological and environmental and occupational exposures. It was a big study looking at 800. None of these patients, or rather a few of these patients had cardiac sarcoidosis, about 2%, but most of them had pulmonary sarcoidosis. They took 800 cases, 800 controls, and they did a very detailed occupational and environmental survey. And what they came up with was they found 3 associations with disease. One was agricultural employment. The second was mold and mildew exposures. But thirdly, they found a negative association with smoking cigarettes. So what we did was we took their questionnaire and we applied it to our patients. So our cases were clinically manifest cardiac sarcoidosis patients acutely, and our control patients were patients with identical presentations to the cases, but were found not to have cardiac sarcoidosis. And these are the results. You know, the sample size was so small that it's not a big surprise that the occupation was a wash. I've highlighted there the agricultural. There was nothing statistically significant with any of the occupations, but the issue probably was primarily the sample size. However, mold was interesting. Mold was positive. And mold, we used the same definition as they had used in the original 2004. Mold exposure was defined as a positive response to any of the conditions in the following question. In your office or indoor working environment, in your employment at the time of your illness, not in the workplace bathrooms, have you noticed any of the following conditions: high humidity, water damage to furnishing, etc., obvious mold or mildew, or musty or moldy odors? And remarkably, nearly 50% of the cardiac sarcoidosis patients reported one of these mold exposures, and in the control group, it was only 25%. So that was a fascinating observation. And the smoking was also very positive. We found that only 8 out of 43 of the patients with cardiac sarcoidosis had a history of ever smoking, whereas in the control group, it was nearly 50% had a history of smoking. And the other thing we found is that we actually looked at we asked all of the smokers, how much did you smoke? And the patients with cardiac sarcoidosis who'd smoked had smoked a lot less than the control group smokers. They had a pack year history of about 10 years as opposed to 21 years. So not only had cardiac sarcoidosis patients smoked less frequently, they'd also the ones who had smoked less. But that original paper was was criticized by many of the reviewers, and we actually had trouble getting it published. And the major criticism was our choice of control patients, which was a valid criticism. So we decided to repeat the study but with a much better control population. So we went to the Ontario Health Survey. Now the Ontario Health Survey is primarily a cancer study that was set up in 2007 and follows nearly 250,000 Ontario subjects. And these were volunteers who came forward and did a questionnaire at baseline about many lifestyle things, including smoking, and then they're being followed in the long term for development of cancer. But these people at the Ontario Health Survey are very willing to work with anybody and give you access to their data. And I found them very, very helpful and very easy to work with. You know, if I compare it to getting data from ICES, this was ICES, this was much, much easier and much, much cheaper. So it took me about a 6-month application process, and it only cost me $4,000, which was nice. And they were always extremely responsive to emails. So basically what we did is we took all of our cases from our own population, and we then matched them with the Ontario Health Survey patients, and they were matched 10 to 1, which improves the power, and they were matched on sex, age within 2 years, 3-digit postal code. Now, 3-digit postal code is a way. It's far from perfect. I'm sure Jody would tell me that it's not perfect at all, but it's a way partially of correcting for social class. We also controlled an ethnicity, history of diabetes and hypertension. And these are the results, extremely similar to the first population study that we did. In the control population, 48% of them had a history of smoking at some point, defined as greater than 100 cigarettes. So one behind the bike shed doesn't count. You had to have 100 behind the bike shed before you were counted. And in the cases, about 28% of them had a history of smoking, enormously positive p-value. But remember I told you about the pack year history? We found exactly the same thing in the subset of patients who had smoked. This is only the ones with a smoking history. The cardiac sarcoidosis patient had smoked much less than the control patients, 8.3 pack years against 15.3 pack years. And finally, we looked at the PET scans in all of the cases, and we looked at the amount of inflammation. We looked at many things on the PET scans. It was truly a bit of a fishing exercise, but we also looked at the amount of inflammation. And the never smokers had significantly more inflammation on their PET scans than the current or ex-smokers. And that was highly statistically significant. So a very consistent message in this study. It's unclear why smokers have a lower risk, but it is known that smoking is associated with suppression of T lymphocyte function and phagocytic activity of macrophages. And now smoking is being explored as a therapeutic treatment for sarcoidosis. I don't mean making people smoke, but there's this one study just published which randomized patients with pulmonary sarcoidosis to transdermal nicotine against placebo. So the small study, 50 patients, randomized them to placebo patch against nicotine patch. And they were followed for 26 weeks, and the primary endpoint was forced vital capacity on pulmonary function tests. And these are the data. The nicotine treatment group had a statistically significant improvement in their FVC with nicotine treatment, and the control group had a significantly had a reduction, and this was statistically significant, but also clinically significant based on their MCID. So this is another ongoing project. We're using the Ontario Health Survey. They have quite detailed occupational data, so we're comparing their occupational data to ours. I don't have that data at the moment. The other etiological investigation that we're involved in is looking at the relationship between propionio, I can't pronounce that, bacterium acne and sarcoidosis. There's quite a lot of data to suggest that patients with sarcoidosis you can find increased immunohistological evidence of P. acne in granulomas from these patients. This meta-analysis suggests the odds ratio was 15. So, quite a lot of circumstantial evidence that P. acnes may be somehow involved in sarcoidosis. But there's only been one paper so far looking at this in the specific cardiac sarcoidosis population, and this was a Japanese population, so nobody has looked at it in the Caucasian population. But what they did in this particular study, very simple thing, is they looked at patients with cardiac sarcoidosis with positive biopsies, heart biopsies, either autopsies or EMBs. They a control group of myocarditis patients and also another cardiomyopathy control group, and 63% of the sarcoidosis patients had P. acne positive reactivity in their samples, compared to none in the other two control groups. So very, very positive studies. So what we're doing, we've done one thing already, and that was in our paper that I showed you already. We actually just asked the cases and controls their history of acne. I read a lot of literature about acne, and there is actually no validated questionnaire for the diagnosis of acne, so I had to make one up. So we just asked them, did you have acne? Of the CS patients, 14 out of 43 had a history of acne, compared to only 6 of the controls, which was borderline significant. But what was interesting was that the patients with the cardiac sarcoidosis had a much longer history of acne than the patients in the control, nearly 8 years compared to 2.5 years. So some hints there. So what we're doing, again, this is an ongoing Heart Institute project. We just got IRB approval. I'm working with the chief of pathology, who's Dr. Vijay Nair, is working with me on this project. We actually have 30 stored samples from of EMBs of CS patients, and also some autopsy samples and explanted heart samples. So we have 30 samples to look at. So what about improving the diagnosis? This is a paper that we did with our MRI colleagues, looking at the reproducibility of CMR. CMR is such an important tool to help us diagnose cardiac sarcoidosis, but nobody had actually looked at how reproducible it was. So what we did is we took 87 MRI scans, and we showed them to 2 very experienced CMR readers who had a lot of experience reading these scans, and we asked them a very simple question: is this consistent with cardiac sarcoidosis, not consistent, or indeterminate? And surprisingly, their agreement was only moderate. It was 72 out of 87 cases, which meets the definition for moderate agreement. So it's important clinically that we know that there's a lot of inter-reader disagreement about this diagnosis. The other thing we asked them to do was we asked them to independently quantify the amount of delayed enhancement. Delayed enhancement is this white stuff here, which basically is basically MRI representation of scar. And you can actually measure the volume of this scar. This is a patient with a small patch. This is a patient with a large patch. And there's evidence from other diseases that the amount of scar you have the worse your prognosis is, from both from a mortality basis, and also from an arrhythmia point of view. And we asked them to read this independently. And again, there was a problem. There was the R squared between the two of them was only 0.516, showing there's a lot of subjectivity to this LGE quantification. And this is important because, you know, there's more and more evidence to suggest that the more scar you've got, the worse your prognosis is. For example, down here, if you had LG less than 20%, you were immortal. If you had LG greater than 20%, you were doomed. So important that we try to improve the quantification of the scar. Next, I wanted to talk to you about disease phenotyping. There's a lot of research in general sarcoidosis into disease phenotyping. This is a large study of over 2,000 patients, which has separated sarcoidosis into 5 main phenotypes. But there's very little data on the phenotypes of cardiac sarcoidosis. I've presented the 2 clinically silent and clinically manifest ones, but there's also some patients who are rapid fibrosers, and also some patients who are non-fibrosers or minimal fibrosers. And there are also perhaps patients who've got an acute form of the disease and a chronic form of disease, but we don't know this. Now, there's been quite a bit of data in pulmonary sarcoidosis patients showing that there are some patients who have an acute form of it, and some patients who have a subacute form, and some patients who have a chronic form. The only way of working that out is by transiently stopping treatment and then looking to see if the disease comes back. And clinicians and investigators are comfortable to do that in patients with pulmonary sarcoidosis, but up until now, nobody has been comfortable to do that because of the risk of the worry about recurrent disease in cardiac sarcoidosis. But we the first group to have done this transiently stopped therapy and looked for disease relapse, and I'll show you the data. This is how our treatment protocol goes. We start with, and these are treatment naive patients. In those days, we would start with 0.5 milligrams per kilogram of prednisone up to a maximum of 40. We now don't use more than 30 milligrams of prednisone. We do a PET scan at 3 months to look for control of disease. If the disease is suppressed, we complete a year of treatment. After a year of treatment, we transiently stop treatment for 3 months to look for disease relapse. And this is our initial cohort of 21 patients who've been through the study and have got long-term follow-up. This is credit to Christian Wiefels and Willie Wang, who wrote this paper up. It's under peer review at the moment. So we took 21 patients, and all of them responded to prednisone to some extent, but 2 of them had a suboptimal response, and 19 of them essentially had a full response to prednisone. And of that 19, they all completed a year of prednisone, and 12 of the 19 relapsed, and 7 out of 19 didn't relapse. So this shows you some individual patient examples. This on the left here is a patient who's a clear relapser. This is treatment naive, prednisone, treatment relapse. This is a patient who's a non-relapser, treatment naive, treatment naive, treatment, and then post-treatment. And this is the summary of the data down here. So importantly, there was no risks. There didn't seem to be any risks to this trial of therapy cessation. It was only 3 months of therapy cessation, and there was no adverse events happened during those 3 months. And also there was no late relapsers in the 7 non-relapsers during 4 years of follow-up. So, you know, this trial of therapy cessation found 12 patients had chronic disease phenotype and 7 had acute treatment phenotype. Now I wanted to show you some of the data on disease prognostication. We have two projects on this. The prognosis of sarcoidosis in general is generally a very benign disease. Patients with extracardiac sarcoidosis rarely die from the disease, and about a third of them don't need any treatment at all. And the prognosis of cardiac sarcoidosis is also much improved from what it was before. But there is still some controversy in the literature about whether it's quite as good as this figure of 92.5% at 10 years. So we're doing two large projects to look at this one. The first one is large database research, working with the wonderful Jodie Edwards in the Population Health Research Unit. I've learned so much from working with Jodie and had so much fun also working with her on this project. So it's a three-step project. The first step is you have to develop and validate an algorithm for the ascertainment of clinically manifest cardiac sarcoidosis. You have to do this regardless for any time you're doing this type of large database research. You have to firstly validate your algorithm. But it was particularly important for cardiac sarcoidosis because there is no single ICD code for cardiac sarcoidosis. Bizarrely, if you look back, there's a code for pulmonary sarcoidosis, there's a code for skin sarcoidosis, there's a code for neurosarcoidosis, but there's not a code for cardiac sarcoidosis. That's not completely true, because in 2017, the latest update of ICD, for the first time ever, there is a code, but that doesn't help us going backwards. So for this type of research, what you have to do is you have to link your cases that you have and some control patients with ICIS administrative databases. So that seems like a simple process, but takes quite a lot of work in the application process and quite a lot of money as well. So, but it's done extremely well and extremely scientifically. And what you do is you come up with these algorithms of using either often Chi-Hi codes, discharge codes, or sometimes billing codes from OHIP. CCI are procedural codes, and you can create these algorithms. You do your best guess of what you think is going to be the best algorithm, and then you look at the sensitivity and specificity. So this paper is just being written up at the moment. It's never been done before anywhere in the world, this type of work for cardiac sarcoidosis. It's actually not been done for sarcoidosis either, so this will be novel. And what we're going to do once we've validated this is then actually start to look historically at the prevalence and temporal trends of cardiac sarcoidosis in Canada. And then once we've done step two, we also have other plans to link to other large databases, for example, Environment Canada data, for example, to look at the environmental exposures. The other one we're doing, looking at prognostication, is this Chr funded study. My friends and colleagues, Dr. Beanlands and Dr. Neri, we've been on this for a few years now, and capturing this large population of patients. This is where we're up to. We're trying to collect across Canada 300 clinically manifest patients and follow them forever. And we're up to 222. We're looking for 200 clinically silent. We've got 103. We're looking for 600 controls, and we've got 239. So we're making good progress. And the beauty of these patients, the administrative databases gives you lots of information, but doesn't give you ability to access PET scans, doesn't give you ability to access blood for biomarkers and etc. But in the registry, we have all of these things on most of these patients. Next, I'm going to talk to you a little bit about what we're doing to improve the arrhythmia management of these patients. The arrhythmia management of these patients is all over the map. And this is our systematic review we did last year to look at the effect of immunosuppression on multiple endpoints points. This table just shows what immunosuppression does for VT. And the bottom line is there just really isn't enough data in the literature to make any conclusions whatsoever. You know, it's always been hypothesized that, you know, if you have a patient with VT, giving them steroids must be a good thing. And anecdotally, everybody's got their cases to share. But, you know, we also know that, you know, the incidence of VT with time regresses to the mean, meaning that patients present when they've got their worst VT, and if you do nothing to them, they will spontaneously improve as well. So whether steroids actually do anything for VT is completely unclear. And it's also very messy in the literature because, you know, these patients are also treated with antiarrhythmic drugs at the same time. And the guidelines, these idiots who made up these guidelines said that you give steroids to everybody with, you know, even with single PVCs. We should even down here, where did it say this? Even give immunosuppression can be useful in CS patients with frequent ventricular ectopy. I don't know what these guys were thinking about. This is our data that we published just recently. I've blanked out one word on the headline of the paper for reasons that will become clear. What we did with this study is we made use of the incredible diagnostics that you get with defibrillators these days. Not all defibrillators do this, but some of them will give you an accurate hourly PVC count. So if you look over here, there was 42 days between interrogations of this patient's device. So it was interrogated on the 12th of April and then on the 24th of May. And down here, if you look, it says this patient had 92.5 PVCs per hour for those 42 days. So we used this information from the defibrillators to try and look at this question. Now, it was more complex. It was quite complex to do because basically their treatment did not line up with their device clinic visits. But we were able to make use of the fact that our own protocol is we don't immediately treat patients with steroids or with anything. Once we put the defibrillator in, we always leave it for 4 weeks to heal before we start prednisone and that, or other treatment. And that gives a wonderful opportunity to look at the effect of steroids on ventricular PVCs and ventricular arrhythmia burden. So this is the number of PVCs that patients got in period one. Period one was the period when they were completely steroid naive. They had no steroids at all at any point, and they had an average of 496 PVCs per day. This is period two, and as you can see, the PVC count went from 496 to 1,332 PVCs per day. And period two is a period where, during which at some point steroids was started. And period three is where steroids were continued throughout the treatment, throughout the period. And as you see, the PVC counts went up to 1,590. So really the absolute opposite to what everybody had been saying for years, that steroids reduce ventricular arrhythmia. There was also an increase in non-sustained VT with prednisone. I didn't show you that data. We didn't obviously have enough power to say anything about sustained VT. So treatment with corticosteroids is associated with an increase in ventricular arrhythmia burden, quite the opposite to what everybody had been saying for years, including the idiots on that guideline panel. What about atrial arrhythmias? Again, we made use of these wonderful diagnostics that you get from defibrillators. Now, if you look over here, it gives you an accurate atrial fibrillation burden, 0.1%, but even more than that, it tells you the duration of the episode. So this patient had a very low burden of atrial fibrillation. All 6 of his episodes were less than a minute long. So we looked at 33 patients. We followed them all for we followed them for a median of about 4 years, and 11 of them had atrial fibrillation in follow-up. But very importantly, only 2 of them had clinically significant atrial fibrillation, meaning episodes lasting for more than 24 hours. We also had one patient in whom, again, who knows what to make of one patient, but this is, if you look at the y-axis here, it's atrial fibrillation burden in percentage of time. And if you look down here, it's serial PET scans. And it seemed to be as the disease got suppressed with time, the AF burden went down, but obviously we can't make too much from one patient. The last area of research I want to tell you about is a little bit about what we're doing to try and improve the treatment. There's so many unknowns in treatment of cardiac sarcoidosis. Again, I come back to the fact, do we need to treat everybody? We don't treat all pulmonary sarcoidosis patients. Many pulmonary sarcoidosis patients are just watched and don't need any treatment. We don't know what drugs to use. We don't know how long to treat them for, and we don't know what the goals of care are. Some people advocate suppressing every single pixel of FDG uptake on a PET scan, whereas other people say that it's okay to just control symptoms and prevent progressive fibrosis. And, you know, the pictures are spectacular you get with treatment. These, again, are courtesy of Dr. Beanlands and Dr. DeKemp, wonderful, and Dr. Wiffels and all these folks. So this is a before treatment scan. And look at that. It looks like you've put out this fire in the patient's heart. But there's never been an RCT in cardiac sarcoidosis. There are lots of 3 systematic reviews, 2 of which we have written. And the data is really very poor, even in the systematic review. The only data that's of any use at all seems to be in the heart block patients. In the literature, there's, I can see that, 178 patients in the literature with heart block treated with steroids, and heart block seems to get better in about half of them. There's 21 patients who weren't treated with steroids, and heart block didn't get better in any of them. So that's the best data that we have. So we do need to do clinical trials. But if we think about clinical trials, choosing the primary endpoint is very, very difficult. There's certainly never going to be enough events to use hard clinical events, even softer clinical endpoints, some sort of composite. You know, again, there's lots of problems with composites. So in the end of the day, you're left with 3 possibilities, either using an imaging surrogate endpoint, a biomarker surrogate endpoint, or a disease-specific quality of life. So I spent many hours with George Wells locked in a room debating all of these, and we eventually decided to go with an imaging surrogate. The other additional consideration when we were planning this trial, and I spent a lot of time reading about this, and there was many people who were not surprisingly ahead of this, and there was a tremendous literature on how to do RCTs in rare diseases. And most of the folks were pediatric oncologists, because, you know, pediatric tumors are so rare, and they had managed to do these wonderful RCTs in these extremely rare diseases. And there were 2 recent consensus conferences of rare disease clinical researchers, and they basically produced a recipe book for how to do RCTs in rare diseases. And the bottom line is you should start as soon as possible. Don't forget about trying to do a registry to define endpoints. Just start with the clinical trial, was one of their message. The second endpoint is the primary endpoint is often inadequately validated, but don't worry about that, just get started, because you will validate the endpoint as you do the trial. Aim for simplicity, and you're allowed to make all these pragmatic compromises on significance levels. So none of this 0.05 and all this, the sample size, type 1 error. You can make all this stuff up because they're rare diseases, and you're allowed to extrapolate from other conditions. So we put all that together and put our trial together. I'll quickly flick through the trial. Our hypothesis is, again, it's an awfully simple hypothesis with the idea, you know, keep it simple because we're the first people doing a trial of this size. We hypothesize that methotrexate and brief low dose prednisone will have a non-inferior efficacy to standard dose prednisone. And we also hypothesize that the experimental therapy will result in a significantly better quality of life than standard dose prednisone. It's open label, but with blinded endpoint analysis, 1-to-1 randomization. It's only patients with treatment naive, clinically manifest disease that get randomized. So just the patients who are at the severe end of the spectrum. They're randomized. This is the randomization scheme. The primary endpoint is this imaging surrogate, which is the summed perfusion rest score, working with Rob de Kemp and Rob Beanlands on this, blinded core lab read on this one. The sample size is 97 patients per group. Again, wide bounds of wide confidence. Wide something, and lots of core labs, PET core labs, biomarkers, MRI, lots of sub-studies. And we finally convinced the IHR to fund this. And COVID obviously was a tough break for us, but we have 54 out of 192 patients randomizing. But the good news is we have, in the last 6 months, we've got another 20 centers. If anybody wants to work in Japan, I can give them all the information that they want to try and work in Japan. The most advice I'd give them is don't work in Japan. If you want to work in the UK, I can give you lots of advice. And again, the advice would be don't work in UK, because these are the paperwork to get started in these studies is a nightmare. So I don't have time to talk about all the projects that we've got ongoing at the Heart Institute in cardiac sarcoidosis, but these are some of them. We'll go back to our case. So this is 2006. We made the diagnosis. We upgraded it to our CRT ICD. Her ejection fraction has been stable. It actually improved to about 30% with the CRT. She was given a 1 year of steroids. She didn't relapse after her steroids were stopped, so she was a non-relapser. And the happy ending to the story is that she and I were on CTV Ottawa in February for a fundraising campaign for the foundation. She did a lovely part of the patient perspective of the story, and that was her. The final thing to mention is that we have this new initiative that's about to be launched at the Heart Institute called the Center for Rare Cardiac Disease. It's basically building somewhat on the success of the Cardiac Sarcoidosis Clinic. Ian Patterson, who's our new recruit, is going to be the director of the center. It's going to be a virtual center, but it's going to have lots of clinics and programs involved in the cardiac amyloid and neuromuscular disease clinic, SCAD clinic, pericardial diseases, a new clinic we want to start, etc. But the project's got many components. There'll be a shared umbrella website, common cardiac core modules, shared learnings. There's going to be an annual virtual conference, which I'm very excited about. The plan is February the 24th, 2023. The idea is that the plenary session will be shared between all the rare cardiac diseases, and it'll be stuff like talks on how to set up a clinical program in a rare cardiac disease, how to do research in a rare cardiac disease, how to do a clinical trial in a rare cardiac disease. And then after that, they'll break into 8 or 9 mini conferences related to the disease. We're also developing a rare cardiac conditions fellowship program, where we're hoping to attract fellows to come in, and they can focus on one rare cardiac disease and do others as well, or whatever they want. So that's the end of my presentation. Just to give some thank yous to especially to some of these folks, Pablo, who's been with me from the beginning in the clinical side of things, and also the research side. All of these wonderful imaging folks couldn't have done it without you, no way. The Method Center, the Populational Health Research Unit team, the Basic Science, Peter and Daryl, all of the coordinators, and apologies if I've missed anybody, students and resident fellow. I particularly wanted to mention Alessandro, who's my first, we created a cardiac sarcoidosis fellowship, which is partly clinical and partly research. And Alessandro is the first cardiac sarcoidosis fellow we've ever had at the Heart Institute, and he's a physician from Norway, and he's with us for a year.
Test. Okay, here we go. David, wonderful. I have to believe that there is no one and no place in the world that is doing as much to understand sarcoid, this disease. I mean, you have to be the leading person in the world on this. It's very impressive, and an impressive journey. So thanks for sharing that with us. And also very excited about the rare disease program, the developments that are going on there. Also to get that conference, that's also fantastic. I have two questions. The first is, you've often said that the prognosis is not as bad as it seems, yet, we do have patients who are coming in with heart block and they seem to be at risk for a sudden death. So that implies that there is something bad that can happen to some of these patients. And kind of a related question for that group. So is there potentially any ways to predict who are going to be those ones who are at risk for sudden death? And likewise, in the study where you have the responders and non-responders, yes, you get the follow-up scan and you see some that improve, but then you're withdrawing treatment, you see some that relapse. But do we have any ways to predict who will relapse? And I'm going to throw in a third question is whether or not there's, is it more than one condition?
Yeah.
Okay. So those three there.
Oh my goodness. Oh, I can't, no, sure, I'm going to remember all that. Anyway, thank you for your kind comments at the beginning. I'm not sure that's true. Only you and my mum think that. So to answer your third question, second question first, the relapse or non-relapse thing, no, absolutely no way of predicting what that is, although it's very interesting. There's just been this publication from one of the Dutch groups on pulmonary sarcoidosis, where they showed that in patients with acute form of pulmonary sarcoidosis, they never found P. acne seropositive, immunohistochemistry positive. Whereas in the chronic patients, in about 50% of them, they had P. acne positivity. So maybe P. acne's got something to do with the subset of disease that's going to be chronic or not. So it also follows that we have no way of knowing which patients are going to relapse or not relapse at the moment. What was your first question again?
On the sudden death.
Oh yeah, so you're absolutely right. Bad things happen to these patients, and the key is early diagnosis for sure. And my first patient, her ejection fraction was normal when I first met her and was 25%. 2 years later, so we missed that. The second thing is, for sure, there's a subset of patients who seem to have VT. I think what the registry will show is that the clinically silent patients are have very benign form of disease, and the clinically manifest patients, there's a subset of them who have ventricular tachycardia. And I think it'll also show that everybody with clinically manifest should have a defibrillator. Certainly, that's our practice, and they do seem to use them. There seems to be a bimodal time distribution of use of the defibrillators. Some of them use them in the first few weeks after they get diagnosed, as steroids seem to hit the disease. They get VF, very horrible VF. And then later on, some of them get VT related to the scar. So,
what about the steroids? Are they doing some of the VT too later?
Yeah, who knows? Yeah, no, we still don't know.
And the other question was two diseases, but I guess that's bit of the P. acne story, and
yeah, it's going to be multiple diseases, I think. Yeah.
So just before Peter steps up, just two comments. Basically, great talk, and thank you from Tahir. And no questions, just thank you for a great talk from Freya. And then Hassan is asking again, excited about the rare disease clinic. What is your approach and general consensus for patients with sarcoid who smoke? Are they referred to smoking cessation?
So
what do you do with the smokers?
Oh, for sure. I think honestly, the benefits of smoking cessation far outweigh over their global health.
Yeah, I was going to say that the conclusion. I'm worried about that pulmonary study, which they're giving nicotine, right? It's really actually not sure the trade-off is worth it. Yeah, so I agree absolutely that this is actually a great paradigm, right, to apply to the other rare conditions as well, right? So I think this sort of approach is really important. And to follow up on the question about subtypes, but also, we're doing these very large, brain and heart disease grant, but incorporating in that is actually a very, very thorough omics approach, to specifically deal with this. So it's actually combining genomics, transcriptomics, and proteomics. Now the tools are much better and actually bring those things together. And hopefully it will actually help us to actually cluster the patients, right? So that I do think there are subgroups, and that will help you to later on, to actually develop more targeted therapy, because then I agree, you should actually start with randomized trials, but then you can do adaptation, right, to that. And so the two follow-up thoughts are, one is that seem to be that it's good actually, so it's the EP folks, kind of pick this up because the EP complications seem to be the most important. And whether, so the patient with these electrophysiology issues, whether you can actually engage, it seems to be that there are global groups who are actually doing this, right? And some of them can still participate in a trial, whether that can be a kind of a rallying point, right? To actually bring the global community together, right? And you can then use that as an opportunity to expand to other collaborations down the road, which would be fantastic because you already wrote the consensus. And so you might as well find out what the disease is. But in terms of etiology, it really reminds me that there is actually very ineffective immune activation. So what happens with smoking, it activates, sort of one pathway and actually, prevents you from having sarcoid. But, when you have these granulomas, and quite often they represent macrophages that actually fuse together, and they actually have trouble, getting rid of the antigen, whatever it is. And so it will actually indicate that, defect. And some of these, with the new so-called clonal hypothesis, that is that as we get older, our immune system acquire mutations. And these actually leads to defective immune activation. So this is kind of the way to explain immune problems in aging process. As we get older, chronic diseases, all inflammation, and so we accumulate these abnormalities. Now there are better tests to actually detect these and to sort them out. So that could, when you have these acquired abnormalities, immunological handling, so that may actually be part of the process. So I think the biomarkers will be helpful, but then later on we can actually try to see if we can actually test these specific immune clonal mutations. Yeah.
Yes, thanks, Peter.
Just a quick question. If P-acnes is actually related with the disease, why don't you start with antibiotics, the treatment?
Yeah, no, it's a great question, and there is a couple studies looking at that. So there's just been one study published where they treated they used a clear group of antibiotics to treat mycobacterium, because mycobacterium is the other one that's been hypothesized, and it was negative, the study. And there's another study that's just finished recruitment, which is randomizing patients to exactly that, treatment for P. acne against no treatment. We don't have the result yet, but yeah, people are thinking along those lines too. But I think the problem will be that there's going to be so many subtypes of the disease that it might help 3 patients in whom that particular bacteria is implicated, but not the other 97 where it's not implicated.
So, David, there's a question from Nina. I'm going to butt in front of Rob, which will almost certainly be a difficult question, and probably be our last one. So, but basically, can you confirm the incidence, likelihood of cardiac sarcoid in the absence of extracardiac sarcoid? Yeah, the lone cardiac sarcoidosis?
You know, we've written quite a lot about this because, you know, it's a huge clinical problem. You know, it's very clear that we have to start speaking the same language, and people are not. So I've in the stuff I've written in an editorial, you know, clinically isolated cardiac sarcoidosis is quite common, meaning that patients only have symptoms from their heart. Is really quite common. But then if you look at, if you do advanced imaging, they'll have disease elsewhere in their body, usually lymph nodes or so on. So that's one thing. Whether you can get truly imaging isolated disease, meaning that you only have abnormalities in your heart and you don't have any imaging abnormality elsewhere, I think is phenomenally rare. We've only convincingly seen 2 cases. And even that is because it's a snapshot in time. You know, if you repeat the imaging 3 months later, it's a dynamic disease. One of the cases we saw extra cardiac sarcoidosis when we repeated the scan 3 months later. So my own bias is that truly isolated cardiac sarcoidosis doesn't exist.
Yeah, I've heard Japanese investigators say it does not exist. You just have not found the extracardiac sarcoid.
Yeah.
Thanks, David. Great talk. Amazing to see the progress. Just to follow up on Peter's question about, you know, omics and blood biomarkers in trying to predict maybe those who are responder or relapsers versus non. I wonder if there might be other imaging biomarkers. So maybe looking at, you know, the state of the immune system, like in the bone marrow or the spleen, for example, you know, finding out whether immune systems are, you know, activated or relatively quiet, might be worth looking into.
Yeah. How do you image the bone marrow?
It's there in the whole body scans.
Oh, okay.
With FDG as well, right? To look.
Yeah, I don't think we had any. We looked at the whole bodies between the 2 groups to see if there was any clues on their pre-treatment, and there was no difference in their pre-treatment and whole body PET scans.
Yeah. Okay. Interesting.
Congrats again, David.
Thank you.
Great talk.
Thank you.
Great work. Keep it up. Well done.